A very warm welcome to you, and thank you for joining us on Health and Wellness. My name is Zaitun Ali, and today I'm coming to you from the Kenya Medical Practitioners, Pharmacists and Dentists Union, the KMPDU, right here in Nairobi. And on set, I am joined by Dr. Dennis Miskellah, who is the Deputy Secretary General. Karibu sana. And I'm also joined by Dr. Malindi Chow, a consultant radiologist in Nairobi County. Welcome to the show.
Thank you.
And the topic of discussion, we just want to talk generally about healthcare and health systems in Kenya. So as we are marking the International World Health Day, the April 7th, the motto is My Health, My Right, of which it's aligning with your motto, which is healthcare is a right. And definitely you're the best fit to talk about this. And as we start, I'll just throw a random question to you guys. Perhaps rate healthcare systems in Kenya on a scale of 1 to 10. Let me start with you, Dr. Dennis.
I think that the healthcare state in Kenya, I would rate it as an aggregate of 4 over 10. 0 is the lowest, 10 is the highest.
Yes.
And it is 4 because the public healthcare system is 1 over 10. Then the other 3 is what the private sector does to uplift to make the average 4 out of 10.
Are you serious?
Yes, about.
Let me hear from you, Malindi.
Thank you. So let me divide it into urban and rural setting.
Okay.
So I think when you talk about the rural setting, it's even worse. I'll give it 3 over 10. Because clearly we've not done anything when it comes to our rural setting. Yeah. Then with the urban setting, I'll still give it 4 over 10.
Okay, yes. And we'll get to that as we are delving deeper into the topic. But let me start with that. What are the building blocks, especially in the healthcare system right now, Dr. Miskellah?
So, in the building blocks of healthcare, especially the universal health coverage that people are talking about across the world and Kenya is adopting now for the third time, is that the first important thing is that you must have the infrastructure put in place, that you must have buildings that patients will be seen in. Secondly, you must have the pharmaceuticals, the drugs for the patient. You must have the technology, the CT scans, the ultrasound, the laboratories to help you with the investigations. Then you must have the technology around the all medicine record keeping, how you're going to be billing it and all that. Then there's the human resource, that when you have set up all these things, there have to be human beings to make them come together to function. Because if you have a building with no healthcare worker, nothing happens. Yeah. The drugs will take themselves from the shelf to the patient. Yeah. And once you have all these, somebody must pay for this. Somebody must pay the worker. Somebody must build the hospital. Somebody must buy the drugs. So healthcare financing is now the overall package. And WHO then goes and adds something called leadership and governance. That once you have availed the cash and all these building blocks, there will be an appropriate and intentional leadership to make sure that they work. Because if you have the money and the governance issues are weak, there will be lots of corruption. Yeah. So for me, that's my opinion around the components that are important in ensuring a successful universal health coverage. Yes.
And talking about the universal health coverage, actually, Dr. Malindi, this is Vision 2030. Where are we at it currently?
Thank you for that. But I think, to be honest, especially when we talk about the HR component, we are still very far. Because we've already seen, according to what WHO requires and according to what we have on the ground. Which literally, on the ground, we are way beyond, because now, according to, we need like one doctor to 1,000, and we are still at 1:17,000. That's the current ratio in Kenya. So you can imagine that HR component alone, we are still very far beyond it. So leaving alone these other components which Dr. has spoken about, so that one alone we are still very far. So that tells you, even if it's grading, where we are. Yeah. Yes. And
UHC is actually very wide, and something that is hot in our lips and in the media currently is the strikes that are going on. You're talking about human resource. Perhaps make the people and the public to understand what is happening with these strikes.
So basically, the strikes are all about what we are fighting for or what we are advocating for. It's all about now the human resource component, where we are pushing for these intern doctors to be posted. Why are we pushing for these intern doctors to be posted? The major reason why we are pushing for them to be posted is because they really play a huge role when it comes to staffing in the hospital. Interns, they actually carry the back part of the work in hospital as being like the immediate doctors who see the patient before now they consult to the second on call and third on call. So that is also, they really contribute to our staffing norms within the hospital and within the country at large, and that's why it's one of our priority things which we are pushing for. So when we say that interns to be employed or to be posted, it's because we know they are doctors and they are working. And when we mean working, it's cutting across. They do surgeries, they start all the way from clerking patients, investigations, and if they need to consult, because we say in medicine, consultation is open, whether you are a consultant or you are a junior doctor or you are a senior doctor, consultation is always important, because now it's about patient care. So these interns, they're actually working across board. When you go to Ops Game, they are there. When you go to surgical, they are there. When you go to kids, they are there. When you go to IMED, they are there. So they're actually doctors who are meeting targets, even exceeding beyond targets, according to the KMPDU logbook requirements.
Yeah, and actually, Dr. Miskellah, you're mentioning about, let's go back to now where they study for this course, medicine. They almost take about 8 years in school. Then after that, what happens? Because how long do they take to be posted in these hospitals to now actually practice?
On the HR component, I'd like to start from the point that, you know, when the government talks about the UHC, you hear them doing the KMSA reforms on the drug supply. You hear the digital health bill on the technology aspect of it. On the equipment, we hear the managed equipment scheme. You hear that they are going to now bring the managed service, bring the equipment and run them. You see the counties building hospitals left, right, and center, dispensaries and all that, because obviously the kickbacks and the motivations are there. You hear the financing, they have brought in the issue of the social health, the insurance, the financing. But nobody wants to talk about the human resource function, which is the most important part. Because all these things, drugs want to see patients that are doctor or a nurse, all that together. So that the challenge that the unions, and not just KMPDU, you'll see the nurses have talked, the laboratory officers have talked, clinical officers have talked. Because out of the whole process, nobody's talking about healthcare. We went to Kericho on 20th of October last year for the Mashujaa Day. The theme was UHC, and we were made to believe that the human resource was going, component was going to be sorted. We have the Kericho declaration on that. That is not done. Secondly, is that Kenyans have suffered from the severe shortage of healthcare workers. When we say that we need one doctor to 1,000, people think that we will say that employ more for the benefit of the doctor. When we say train more, people think that we're doing a favor by training a doctor or for a specialization. But think about this woman who this morning woke up and the baby was having fever the whole night, probably had diarrhea. Yeah. And she has to decide that if I go to the hospital, I'll stay the whole day to see that doctor, one doctor who has to see 200 patients. And if I do that, then I might not go to my job or to go to that Mangafua job to get that 300 shillings to come and feed the other 3 children. So she's torn between going to the hospital with a sick child or going to seek money for earnings for the day. She goes to the hospital with sick hand. She goes to seek the food, she comes back, baby is dead or complicated. Yeah. That's the choice that face homes every other day. This person. Think about this old man who's been so that he has an enlarged prostate, could be cancerous. Let me talk about right now. I have a relative who has this swelling in his stomach and is torn between if I go to the public hospital theater, you have 4-month waiting queue because one surgery in the whole county. If I go to private, I'm going to prepare 50,000. Do I sell the only cow I'm milking? So the shortage is real and it touches on the lives of Kenyans. We have 10 women die every day from cervical cancer in this country. 6,000 being diagnosed every year from cervical cancer. And when they come, as healthcare workers, you tell them, you came late, you're in stage 4. Why did you come early? But this one then tells you that no, I went to the dispensary, which I didn't find a doctor, I found a nurse who told me the UTI. Then I went to the health center 4 months later. I got to the clinical officer who told me no, it's a fungal infection. Yeah. By the time I get a chance to see a doctor, by the time I get a chance to see a gynecologist, is 1 year, 2 years down the line and I'm in stage 4 cancer. So you don't come blaming that I came late. That is what we're telling the government, that it's good to hire the CHPs, but that are just creating the need. You tell this person you have hypertension, go to the hospital. You have diabetes, go to the hospital. But when they arrive in that hospital, it's not a doctor. You've not solved that problem. You only made them worse, depressed and worried. That's the challenge that the human resource portends for the Kenyans and not for the workers.
But are we even training these community health workers to at least now sensitize the people, do health educations in the society? Are we even training them? At the very basic level.
First of all, in the hiring of the CHPs, the only qualification is that you have a nose for breathing. They have zero knowledge in medicine. They just speak to the villages.
They're not even CHPs. They changed the name to promoters.
They're not CHPs.
Community health
promoters, yes.
Okay.
Yeah, because the politicians wanted to put their people on some payroll somewhere. They don't, how can you educate somebody on family planning when yourself, you don't know anything about it? Yeah? So it's just a big joke. And I think my friend can tell me your experience in Nairobi here. I didn't do anything much.
No. Actually, we even got in touch. I have a friend who is in Nakuru. She actually sent me a text telling me, by the way, we've never seen those people on the ground. Oh, no. They're not being seen anywhere. Yes, they are there. They're on a payroll. They are somewhere outside there. But on the ground, they're not being seen. Really? Yes.
I think I met with others from Kajiado. They were really doing a good job in terms of sensitizing people against tuberculosis. Asa wacha ni watete wa Kajiado wako sawa, labda niseme hivyo. So we need to look at that. And it brings me to my next question, whereby once we did the devolution thing in this country, 2013, and now the health sector also did devolution in terms of giving county government service delivery, and then now the main government handling the policies. So did this do more harm than good?
To be honest, I think we rushed into the devolution. That is what I can say. Because I think we didn't give ourselves time so that at least we can do it like stepwise. Yes. Actually, if it was in my position, they could even have done it maybe like they do like a pilot so that they see how it can actually work. Because currently we are having a challenge, even us in the county level. Because now you see the way county prioritizes their things is totally different from how we prioritize our things. Because now when it comes to healthcare, let's give an example of Nairobi County. Now that we no longer have NMS and everything was handed back to Nairobi County, then what has happened to those facilities? We go back to, the structures are there, buildings were built, yes, but nothing is happening. Because now the Nairobi County comes, it starts arguing that it was not part of our projects, these are not part of our projects. Instead of them picking up from there, they start fighting. But if it was a national function, I'm sure nothing like that will have happened, because now you pick it up from where it was stopped. It won't be like, it was my project, it was their project. So for me, I think we rushed into this. Yeah. Health deserves to be in the national, so that everything is actually handled, not only policies, but even managerial, everything is handled at the national level. After all, if it's our money, all money is coming from the exchequer from the same point. Okay. Yeah, that will be my...
That makes sense. Yes, Doc.
Is that devolution has done more harm than good to this country. And I can assure you that the ultimate price you're going to pay will be felt 30, 40, 50 years from now, when the current crop of leaders are probably exited. And as young people will be in that age when you need that healthcare. And it won't be there. In 2010, when the devolution was coming up, we told the then government that be careful, let's take time and put structures. The transition authority was very clear that let us put all the steps to ensure that we do these things successfully. What did they do? They said, no, President Uhuru Kenyatta, you are fighting devolution. When the union spoke up, they said, no, we are against being supervised as a closer level. Okay. You be patient, there's a teething problem. 14 years down the line, we can't still have teething problems. Yeah. There's a problem. And yet, nobody sees that there's a problem. Because the lack of leadership and governance. The president will do a task force on education reforms, task force on prison reforms. I've not heard him know about task force on healthcare reforms. Nobody seems to see there's a problem. This governor is only there for 5 years, or maximum 10 years. So he cannot have a long term. Yet, a country only develops when they have a short term and a long term plan on issues. And as KMPDU, I've told you that, look here, there's certain things that could have been done. Did you guys even take time to unbundle what healthcare is and the costs? Exactly. But you have these politicians who came from, who thought that they see the private hospitals making profits
with these hospitals, they want to make profit. But healthcare as a social function must be a loss-making venture. The moment public healthcare starts making profit, somebody's going to be dying. Somebody's going to suffer. Yeah? And that's the challenge that you have seen over 100 strikes ever since the revolution came. We only do these national strikes when the issues become too much. And as healthcare workers, the biggest frustrations for us is that when you have a problem and you go to the counties, they tell you, no. The problem is the national government, that's why the money is stuck.
Really?
When you go to the national government to tell them that is a problem, then no, you guys are devolved, go to the county.
Yeah. So
everybody keeps on toasting you. The only time they agree is when it's about tenders as business. For example, the managed equipment scheme. The MOH procured and sent them down to the counties. When they're building hospitals, MOH has made deals with VAMED International to build hospitals. You see this mother's child being opened all over the place. They are just doing it. When it comes to drugs, these camps are centralized, they are spreading it out. When it comes to financing the shift, they don't allow every country to do their own. They are being central because of the money. But when it comes to the human resource, they didn't know. We are devolved. That's not my headache. That's what is ailing healthcare. Lack of leadership and governance issues. Plus the corruption that accompanies the whole process.
Yeah. And we've talked about that, and something that has kept on arising is now health financing. How can we even demystify the myths whereby people know that public health institutions are not well equipped, you can't find the best doctors unless you go to the private? How can we demystify that?
I think from my end, now that we've actually, I even wanted to add to what Dr. has said, actually working in a public facility is like a voluntary job.
Why?
Now, when you look at, it's only that doctors don't come out to the public to say what they go through. To be honest, we've actually done a CS with Mulika Muizi. You're being mulikwad for you to remove that baby. Because you have to save the mother, you have to save the life.
And there's no electricity?
Exactly. There's so many things which have happened in such a way that we really don't come out. If all doctors from these public facilities actually come out every day to say what they undergo when they see their patients, people will be shocked. People will be shocked. Now, this is the same, why am I saying like it's like we are doing voluntary work to the community? Because this is the same, if it's a neurosurgeon operating on a patient in a public facility, that procedure will be even from NHF itself.
Yeah.
It will charge very low now that this is a public facility.
Okay.
But the same doctor will go to the other side of the road, and that same doctor, the price will be way up. So if at all, and these are the same people, it's not like they're different people. So if at all these public facilities really need to work as efficient, then they have to put money in these hospitals. They have to finance these hospitals, because we are ready to work as doctors. But imagine going to a hospital where if your patient needs some blood, there's no blood. You don't have. By the time they start calling relatives that this mother needs blood, this needs blood. I mean, we've already lost the patient. So you can imagine even us as health workers what we go through. You're leaving your house in the morning. You are meant to go save a life, but unfortunately, instead of saving a life, the other things happen.
And I agree,
it's
because
so depressing.
There's someone who mentioned that a friend of mine, a doctor in Elgeyo Marakwet, who said he actually refused to be a doctor anymore because he wanted to take up leadership in that hospital. There's a time during Christmas, he lost a patient because there was no blood. And it's because it was Christmas season on 25th. Doctors awako, wameenda festive season, and you cannot get any donation for blood. So these things happen. And as the union, how are we doing, what are we doing actually to help the situation, Dr. Miskellah?
Doctors are tired of supervising deaths.
Yeah.
As a union right now, the biggest problem I'm dealing with is depression amongst my members. This year alone, I've lost 4 doctors to depression. And so much more who are struggling with the alcohol abuse and drug abuse because of the coping mechanism of the sadness we see in the hospitals. Remember that these doctors come from the community. We are not picked up in mass winners. We come from these communities. We feel the pain of our patients. We feel the pain of those children who have to die at the age of 3 because the system failed them. You know? And when we go speaking up and this woman comes with this emergency, and before you take her in to deliver this baby, she has to go buy cotton, she has to go buy gloves, she has to go buy the antibiotics before going to surgery. And it's 2 a.m. in the night. The pharmacies are all closed. And then you have to lose this mother because of this. Yeah. All these children have to die because the antibiotic that would have saved their life, you prescribed for the mother. And she has to go look for this money in the slums, finally buy that drug and come. You know? It kills us. So we are doing a clinic on this woman with cervical cancer, and she arrives from Homa Bay, And when she lands overnight, you don't know that to feed her first before you treat her. Because until you have to come back next week, like, I don't have fare for that. We have underinvested in healthcare in this country because we don't care about the masses. We talk about healthcare financing, and I'm so proud that somebody talked about the social health insurance fund. But in a country like ours, where 80% of the population is in formal sector, only 20% are on a salary. How are you going to affect that? How are you going to make this motorcycle guy pay for this? You know, in the long run, they'll only pay for this shift or the chef when they're having a broken leg. Even if you told them to pay for 2 years, that 500 times 2, they have 12,000. Fixing that broken leg will cost over 100,000. So you end up suffering from what we call adverse selection. You cannot make finance health on that aspect in Kenya. You can do that in Germany where 80% are on salary. So you bill them on the salary and they carry everybody else. But right now, since we only have 20%, they are overburdened with this 20% with carrying this burden. We have suggested to do what Ghana did. Why can't you say that 2% of the VAT goes to healthcare? Everybody pays VAT. When you buy sugar, you pay VAT. When you pay fare, you pay VAT. That is a better way of financing healthcare. Then once that money has been availed, you have to reface it against things like corruption and the political interference. Because governors, when they get the money from that maternity hospital in Runyenjes, and the money comes to the accounts for the county, they'd rather buy iPads for MCAs and take them to Zanzibar to bribe them than take that money to replenish the stocks of the maternity ward. So we must get to a place where we intentionally finance healthcare. The Abuja Declaration over 20 years later, the 15%, the highest we ever came to close to it was 8%. Right now we are around 3%. So we keep on losing and losing and losing more. And the solution I'm telling you is to build more private hospitals. So that the latest research shows that 56% of Kenyans access their healthcare in a private hospital.
For sure.
And not at the private for the a good setup private, the big private, no. They're not called private for poor. You see them these cases where somebody is a nurse, she's the doctor, the accountant, the front office, the lab. So people go there simply because you don't want to queue for 6 hours in the public hospital. You have to go for this private for poor. Ending up with the deaths, complications, you still end up in the public hospital with a more complicated case or a life lost. That's the tragedy of healthcare in this country.
That is so sad.
It is sad, and I wish Kenyans will get to a point that they see that this fight that we have as KMPDU is their fight. The politicians, the entrepreneurs, the business people will want to see this from the business aspect, collapse the public healthcare system, drive them to private hospitals for them to make money. But remember that a person who invests in a private hospital is not doing it because they love you. They're in business. When somebody operates a butchery, they don't say it because they love you. They're in business. So that the cost of healthcare will keep on rising. People will only be one illness away from poverty. You feel I'm Miskellah, I'm a consultant, mid-class, comfortable. But the day I call that my mother has a stroke and she has been in ICU for a month, I'm back to poverty, complete poverty.
True.
And that's why you even ask the middle class that every single day the money could have used to invest is hemorrhaging away to finance healthcare in private sector. Let us join hands to ensure that the public hospitals in this country work. And not just public hospitals, every public responsibility. Because when every time the public transport system fails, you have to take a loan to buy a car.
True.
Every time the public schools have failed, you have to take your child
private
to an academy.
Every
time the water taps are not there or clean, you have to buy a dispenser and a water bottle. So that you pay taxes for 6% of your salary on taxes, then the little left, you have to use it again to do what the taxes should have done. That's a tragedy.
And actually, I think we don't learn as a country. We were just from COVID pandemic. And I'm just waiting, even you as now, the media people, you can actually move around the country. Try to see how many counties so far have developed an ICU.
Control and prevention measures.
Exactly. That time, and you know, with this climate change which is happening, there is another pandemic coming. The frequency of pandemics will be even much closer. But have we learned from the previous one? No. This Nairobi County, we have 5 million people. How many ICUs do we have? We only have ICU in Mama Lucy, which I think it has a 3 or 6 bed capacity versus 5 million. So what about these other counties? So you can imagine where we still don't learn from experiences. Because by now, I think that was a learning point where we could have prioritized health And by now, all counties will be talking like if it's ICUs, they're well equipped in all counties across.
Sure.
So that if you need an ICU bed, you don't have to be airlifted from Kisumu to Nairobi or from Lodwar to Nairobi or to Mombasa. At least you know if you need an urgent ICU or anything care, it is within it's accessible within your county. But look at what is happening on the ground.
In fact, on the COVID,
yes.
the tragedy that came.
Even before you can talk about this, we want to just take a short commercial break, and then we come with more about now the disease control and prevention measures. We want to know about the SHIF versus NHIF, what are we doing about it, and the goals for now the health sector as a whole. Vision 2030. So I'm still joined right here by Dr. Miskellah and Dr. Malindi from KMPDU, and we are coming shortly. Don't touch that dial. Welcome back. If you're just joining us, remember this is Health and Wellness. My name is Zaitun Ali, and before the break, we were just discussing about the medical health state right here in Kenya as we are marking the International World Health Day. And joining me from KMPDU is Dr. Miskellah, Deputy Secretary General, and also Dr. Malindi, who is a consultant radiologist right here in Nairobi County. Karibuni tena. And we've been discussing about how facilities are looking like, medical facilities are looking like from private to public health sectors, how the doctors are actually managing financing of these health facilities. And right now we want even to delve deeper into, we were talking about COVID preparedness from what we learned last time. How prepared are we, Dr. Miskellah?
Africa, generally, and Kenya specific,
yes,
was spared. I say spared from the tragedy of the pandemic because the countries that lost millions. America lost millions, countries like Italy. Are there countries that have functional health systems? We got away with it for one reason or the other. And it breaks my heart that nobody has taken time to draw any lesson. We thought that we would be a task force on the lessons learned from the COVID for the pandemic preparedness. I see the government and the president is really up there championing for climate change. And I can assure you that with the climate change, there are going to be more pandemics. The world has become a global village. Today you are in Kenya, and the next 9 hours you are in London. Another 10 hours you are in Australia. So one person with one infection, by the time they pick it up, you have gone to 10, 20 countries, probably, if you travel widely. So we as a country must put our house in order. You cannot play politics with healthcare. I saw during COVID, some governors, they are each given 300 million to do something around the infrastructure. And I saw some governors even going and hiring beds and then say that they have set up an ICU. And ICU is not a building, but right, ex-country ICU. An ICU is not a bed. An ICU is not a monitor. An ICU is a doctor, an anesthesiologist, an ICU nurse, and the attendant support system. How many have they trained? Have you even heard them say that we are going to train 100 anesthesiologists? No. Have you heard that they are going to train ICU nurses? No. Instead, the government has gone ahead to export the few ICU nurses we have across. Don't think that the UK loves Kenya so much that they come from our nurses. Don't think that America loves Kenya so much that they come from our nurses to give you back their smart maintenance. No. They are taking their best because they are setting up their systems. We lose right now almost 10 nurses per month. Going abroad. To the US. 3-4 to the UK. And we take the best of the best. If they really wanted to help us get our jobs for our members, they'll be picking them from the Registration Square. There'll be a bus in London Express, where as you be like, they tell you that I've given you a job, come. But they don't need those fresh graduates. They take the ones working, and you guys take those working in industry. They want a level of 4 or 5 kind of nurse. And they prefer the ICU nurses, nurses, oncology nurses, the best of the best. In Nigeria and Ghana, they lost so many specialist nurses that became
a crisis. And that is simply going to happen. The doctors are still going to leave because of how they are being treated. And Kenya has stopped training doctors for masters, for specialists. So you'll have a bunch of doctors who are, after internship, they are jobless. They didn't get a chance to specialize. Training stopped. Then the consultants, they grew old. Some of them died. There's a gap. That's when you know that this country has managed the healthcare. Another pandemic is going to come very soon. And I'm not a prophet. It's because how the climate has changed.
Yeah. What about this one that people are saying, another variant for COVID?
Variants are going to be there because viruses don't die. Changing.
Okay.
Yeah? But there's still going to be another pandemic soon. And we might not be so lucky. And the good thing and the bad thing about pandemics is that when they happen, every country locks its borders. So even the same politicians who refuse to fix this up, they'll be caught up in this mess right here. They'll carry the same fate that they put Kenyans through. Right now, they don't seem to care because when they fall sick, they go to private. When they fall sick, they fly out. But pandemics, when it happens, every border is closed. Kila mtu anacheza kwao.
Kweli. And you're talking about accessibility in terms of how can people access health facilities, and also what are these level 1, level 2 types of hospitals, sub-county? Maybe you can explain this more, Dr. Malindi, now working at the Nairobi County.
I think I'll still divide them into rural and urban.
Okay.
So we have level 1 up to level 6, where now level 6 is our referral hospitals, which now we can actually count them in Kenya. Like Moi referral is actually serving the whole of
Western Gishu, Western,
of Kenya, entire. Then maybe Nairobi, we can say we are somehow lucky now that we have Kenyatta and also have KUTRH.
Yeah.
But now, for now, when we really look at things on the ground when it comes to rural, at least within Nairobi, since we are concentrated, we can say accessibility is better. But now when we go back to mashinani, now that is where the problem is. Because now if I go to my rural home, which is now the Taita Taveta, and my county hospital, which was now Aveso Hospital, it was actually a county referral hospital. Unfortunately, now it was downgraded. So you can imagine a hospital being downgraded instead of it being promoted even higher. That tells you there's a huge problem which needs to be sorted. So from level 1 is just like a health center where it's managed by a nurse. You can find a nurse in charge. Then you go higher to level 2, where now from level 2 you'll get, now there'll be a CEO and several nurses also. Then now we go higher now from level 3, level 4. Now from there you start to see, actually nowadays we have medical officers, even consultants at level 3 and level 4 hospitals. Level 4 hospital like Madare Hospital, that's a level 4, and you actually find a consultant on the ground.
Okay.
They are there. So that tells you that people, like healthcare workers, they actually want to give quality care to the Kenyan citizens. But unfortunately, we are also being limited. Now when we go to level 5, the examples of like Mbagathi, Mama Lucy and Pomwani, those are graded as level 5 hospitals. So now from there, so they are like Mama Lucy, it's a referral for eastern part of Nairobi.
Nairobi, yeah.
So you can imagine the level of people it deals with. Like Mama Lucy, averaging on a day, it can see around 3,000 patients in a day. Mbagathi, same thing, averaging to 2,000, 2,500 in one day. So you know, when we think about healthcare, when we think about HR, it's because now we know exactly what is on the ground. Imagine seeing 3,000 people. One day just walk in that outpatient, any of these level 5 hospitals. See how many doctors you'll find in outpatient who are seeing patients as the first point of care.
Yeah.
You'll be surprised. So when you talk about mental illness, it is real. Because you are seeing the fact, you're not supposed, by the time you, average you should take like 30, 45 minutes with one patient. But when you look at the window and you see the queue of patients waiting, you'll be forced to rush through things. And by the time you'll be seeing you are 50, 60, 70, you are tired. Psychologically, you're even tired.
Yeah.
When you'll be talking to a patient, the other patient atakuwa anaona nyewe daktari amechoka. Haujakula because you can't even break for lunch. Because they literally beg you, daktari usiende, see please utuone kwanza before uende. They can't even understand that wewe una njaa, you're also tired. But you know, you have to fill in the gap. And people, this government does not even appreciate the gap which we try to fill. These level 5 hospitals, the doctors are there and the nurses are there. All cadres across board, they are there. But now we still need more. Because why? The higher you go, even the demand increases. Somebody who is in level 1, when they're referred to a level 5 hospital, they're expected to get a special care.
Yeah.
Yes. So when we are saying that we need to train more people, it doesn't mean that we're enough. No, we are not. Even in Nairobi, if you ask how many neurosurgeons do we have, you'll be surprised. How many orthopedics do you'll be surprised. So if at all, even our governor said he wanted to lead by example by being the first, giving first-class healthcare. But you cannot achieve this without human resource. Okay. You have to have human resource for you to achieve it. And that one can only be achieved by them sitting down and making sure, actually prioritizing health in terms of we also need finances for this. Because if it's about HR, it comes with everything. If at all you employ a gynecologist, that gynecologist will give out a demand. I need a nurse, I need a theater nurse, I will need a circulating, I will need all that. All that, it seems down to, I will need a sonographer to scan to find out if the baby is okay, all the way. So it's not about doctors. Because if we know we are targeting at the highest, because we know if we aim at the highest and we get the best at the highest, definitely a doctor cannot work alone. True. It will trickle down all the way. It's a whole team. Yes, it will trickle down to all these other cadres being employed. So in urban areas now, that one we cannot, in rural we cannot even talk. Mothers deliver on their way as they are being drove to these public facilities because they are kilometers away apart from each other. So you can imagine, we are still way beyond. And we'll come back actually to maternal health care, as you've just mentioned. But as our theme this year is My Health, My Right, and even for doctors, you mentioned about mental health. What measures are being put in place at least to attend to these doctors who are not mentally and psychologically okay because of what they're dealing with in the industry?
I think our government has failed us, not just Kenyans, they also failed the healthcare worker. Because every time KMPDU and healthcare workers become restless and agitated, you're being told it's a calling, you're being told you made an oath. But the first oath that people make is an oath of leadership to take care of Kenyans. And you have to take care of me as a healthcare worker for me to take care of the patient. There's no way as a mother you're going to frustrate the nanny, the household, and harass her. Then you walk out and go to work and expect this nanny to take care of your child. That's what they're doing. They think that they're punishing us. When they don't pay us on time, when they don't meet our statutory deductions, they think that they're punishing us. Ultimately, the person they're punishing is Kenya. Because if this doctor is sitting behind that desk and they don't have their salary, and it's just been called that his mother is sick, his child is sick, there's no medical cover, that doctor is mentally switched off. And medicine is about skills, knowledge. So when I can't think about you, when I'm thinking about my house being locked by the landlord, you get that? When I am on my 200th patient, because I'm the only one working, I won't treat that 200th patient the same I did to the first one.
Yeah.
You get that? When I want to do a test and that test has broken down for the last 1 month and it has not been fixed because the money for fixing it was used to buy an iPad for an MCA, I'm a first doctor. And it's the patient who carries that money. In access to healthcare, there's what we call the 3 delays. The first delay has always been the delay of the patient making a decision that I'm sick and I need to go to a doctor, not to a witch doctor. I need to go see a doctor, not a pastor. That's the first delay. That luckily with people going to school and with the CHPs being there, is being fixed. The second delay is in that patient now say that I'm going to the hospital. And how far is that hospital? Do you have the transport mechanism? Do you have fare to access are the roads okay for this pregnant woman to be carried safely to that hospital? The distance. That has been cured partially by politicians building dispensaries and hospitals all over the place. But it is being hindered by those places just being empty facilities. You have one nurse not equipped in my dispensary near home. When she goes on leave, they have closed. When she's sick, they are closed. When she's an emergency, it's closed. Finally, when this patient after struggling, coming all the way from Tenerife to Malindi, then the other delay comes in that there is one gynecologist or 2 nurses in the maternity. This one is going to have a ruptured uterus. She's contracting. The delay in them now seeing the doctor and the right things being done. Is the theater working? Is the equipment available? Is there a power blackout and no generator? So that's the third delay. That finally, when all these delay, one of these delays occurs, you lose that patient. And when you lose that patient, goes to that broken system. the person who feels most broken is a human part of that component. Because the machines don't feel any pain when they fail you. Is a doctor, the healthcare worker who now see that, wow, this one has lost 2 weeks because of this delay from Tana River to Malindi. They are heartbroken. You live feeling sad that you could have done something different. Then the depression sets in. Then before you know it, you are probably abusing alcohol or drugs. Then the PAC guideline is that you don't fire such an officer, take them for rehabilitation.
Okay.
What does the county do? Oh, we didn't levy, they stop your salary. Spiraling down until finally suicide. I know that physician suicide is the most successful suicide because we know everything. We know which drug you can use for the most painless death. So then you ask them, what have you put in place to take care of this? Who cares for the carer? What is the mechanism of this mental illness? Who cares for the carer?
Yeah, that's the question.
And nobody. Right now, all the burden is shifted back to me. I have a welfare committee where now the headache is, where do I take? I don't have money. Where do I take these people? Remember that these people also were colleagues. How will I work with my colleague that I'm suffering from drug abuse or alcohol abuse? And we're in the same profession, we know each other, classmates. So you want somewhere, a safe space, which nobody has provided. That's a tragedy that the healthcare worker has to carry every single day. When this patient dies and they go complaining in the media, the politicians, they come with a camera in tow and then fire these medicine. Fire them and make them look like they're the worst people in the system, like in Mama Lucy, where you go bad-mouthing the doctors and the nurses. The only 2 nurses seeing 70 patients. We lose this one who is in labor, who is delivered, who is delivering, okay. You have to take her to theater. Then there's already a patient on the table being operated on. What do you do? You're one doctor. So they choose the easiest option, blaming the doctor, not blaming the system and doing something about the system.
Okay, that makes sense. And you as a SecGen now, especially now, kindly create something, a welfare, a safe space for these doctors also, to tafuta watu mshikane. Kwa sababu enyewe tunaambiwanga kinyozi ndio ajinyoi, lakini hapa itabidi madaktari watibiane. Yes, at this point. It's really sad.
Created that space. It's overwhelming. That's why in this strike, our rally call was that we have nothing more to lose but the chains. And we told our members that for us as the leadership, we don't mind being jailed. We don't mind even us dying. The only thing we can offer our members is our lives. Because we have said this for the last 7 years. We have a CBA that addresses these welfare issues, and nobody is keen on them. So we will continue doing our bit, but we must be ready to lose it all to gain anything.
Okay, Dr. Malindi, maybe we can briefly talk about maternal health. So in terms of even health education, something as simple as family planning methods, contraceptive methods, how far are we at educating these women? Pale mashinani.
So thank you about that. So I can say in terms of like now the family planning exposure and all that, the only challenge which we have experienced is now the myths which come with that. For example, now when it comes, I remember there's a time where women used to say the depot it's meant for ng'ombe. So kwa village, watu wanajua hiyo ni shindano ya ng'ombe, but sisi ndo tunapewa huku. You understand? But now when it comes to now this, they've said the level 1s and level 2s, when it comes to now availability of the family planning, they are really trying in terms of, we have different types of contraceptives when it comes to if it is protection, am I using pills, am I using now the depots, they're actually available. And I think Dr. being a guy, he can even elaborate more on the same. So there is a step when you go down on the ground. The only disadvantage is now that most of the time people tend to get here and save from outside rather than coming to the daktari to consult even more. Because now, and unfortunately, even these mothers, they tend to believe ya uko nje zaidi ya what the doctors tell you. Because now like a radiologist will get a mother who has come, maybe mtoto ameketi, tunasemanga mtoto ako bridge, tunamwambia mtoto ameketi. So for her, she believes kuna mama pale kwa ground who can turn the baby. You understand? So kuna mama mwenye anaweza nifanyia massage a baby to rotate. So these are some of the things which actually are they're increasing a mortality rate when it comes to maternal and child health. Kwa sababu for her, she believes kuna mama anaweza mfanyia massage, change. So until that one is changed, ile mwambie no, mama, hakuna kitu kama iti, mama ataenda kugeuza huyo mtoto. Please, if this baby does not turn, by the time unaenda kuzaa, make sure that you go to hospital very fast. So ngoja hata iti contractions zianze for you to rush to hospital, because now the chances of complications are very high. So if they don't get that information, wanakaa wanaenda kwa that mama aende ageuze mtoto, so they believe mtoto amegeuzwa, then they just wait until when it's already too late there, both of them, the mother and the child, are also at risk. So I think we need to create more exposure and talk to these mothers down here so they can know the risks they have, especially when they are pregnant, or how they are exposed more.
Thank you for creating awareness on that. And even as you're winding up, there's something that we need to talk about very briefly, and it's about the SHIF and now the NHIF. So Social Health Insurance Fund and then now the National Health Insurance Fund. So where's the discrepancy? And are we really now turning to SHIF permanently? And what is SHIF? Because sasa watu watakuwa kikatwa hiyo tax and everything. You can let the people know.
We are glad that we never face our problems. The NHIF and SHIF situation is a case of somebody who has seen a snake walk into a building and they decide to bring down the building and burn it down completely. Somebody woke up one day and said that there was corruption in NHIF. And that solution was to go to jail the corrupt, prosecute them. The solution was to bring down NHIF and build another one. The motivation, if I could give a theory, is that this person who brought down this building probably has a construction company that has to benefit from building this new building. Or they have put a plan in place on something. Because NHIF has served us pretty well.
It has.
For over these years.
Yes.
If there's one thing that I will never forget the Uhuru Kenyatta government for, is how he made NHIF be at the center of everything. My mother is alive today because of NHIF.
True, Linda Mama, everyone knows
about
it.
So, and these kids in school and all that. So for somebody to just wake up and say that they have these changes. And Kenyans must know that the Social Health Act, because that's the law, the Social Health Act has 3 components. The Permanent Healthcare Fund, then they have the Social Healthcare Fund that Kenyans contribute. The Permanent Healthcare Fund comes from taxes. The parliament will allocate money to it. Then the Social Healthcare Fund comes from what we contribute to all of us. Then finally, the Emergency, Chronic and Critical Illness Fund, also from the taxes, not contribution. So they have these 3 funds, which first of all don't understand why they have to have all these 3 funds, because it just brings confusion and avenues for corruption. Because you don't know when you're using one and when does one end to go to the next. Intentionally, they brought that confusion. Secondly, the other issue that they brought around, which is going to cause trouble, is the claims management. That they're telling you that after collecting all this money from the public, then you hand it over to a private company to manage that money.
So SHIF will be from the taxes that we're going to pay?
So,
or
Social Health Fund, the SHIF, is from your contribution.
Our contribution.
The Primary Healthcare Fund and the Emergency and Critical Healthcare Fund, they are also from the Parliament budget. So they have these 2 funds from Parliament, then this contributory scheme. So that confusion, the 2 funds by this 1 fund.
So whether employed or non-employed, you will still contribute.
Either through tax or now through this contribution. And people are going to contribute from as low as 300 per month to as high as 2.75% of gross. So like for my members, after giving out the 4,000 shillings medical allowance that we gave up in 2011, they're going to take 2.75 of my gross salary, probably let's say 300,000, that's around 8K. That's a form, that's 12,000 per month. 12,000 that I give per month, and when I look at what am I going to benefit from this, is not, we are not very clear what are we benefiting as workers of the world.
So is it not working differently from NHIF? Are we not seeing an added advantage for this one?
After we asked them, right? Tell us this added advantage you're going to tell us. Because if you tell this me, and I experience this when it's working in Embu, where they all contribute faithfully 500 shillings per month. But when they come to the hospital, there's no drug, there's no lab. We have to send them out to buy those drugs and do those tests. Then the patient ask me that, then Hajagani, why do I have to contribute 500 shillings per month when I come, there's nothing in this facility? And the same thing, doctors are saying that, why should I give 12,000 per month to this? That when I want the service, I want to get it, because as we know that those hospitals don't have these services, we work inside there. So until you fix the facilities, build, buy drugs, employ more and make them functional, you cannot start with the easy part of it, the money part of it, and forget the service delivery part of it. So SHIF is good, but they have to intentionally sort out the gaps around the healthcare delivery systems. That's what I want to challenge them to do. Let them ensure that once these Kenyans have painfully contributed, wasiende pale mtu amevunjika, mtu apikipiki amevunjika mguu, then is being told that we don't have implants. So they have to hang the leg for 9 weeks as they lose. And the other question I want to ask them is that how they are going to know that this person can pay, this can't pay. It's not clear. Because they're saying they're going to do the mean testing. Question that how frequent? Because if today you came to my home and I have 3 cattle, cows I'm milking, I get 50 liters per day. You tell me you can contribute maybe 1,000 shillings per month. Then this anthrax disease comes.
It's seasonal. And
it kills all my cows. When you do then come again and say that this guy had cows, but they're no longer there, so he can't pay. This motorcycle guy, if you came and told us he's a motorcycle and do the guy, and he can give 500 shillings, then whoever financed him to get that motorcycle, or he gets an accident and the motorcycle is written off. When will you come to now review that this guy no longer has a motorcycle? Now you need to pay for him. How frequent is the mean testing to know how much somebody can contribute?
Those are good questions actually to the government and the policymakers out there. And as you're winding up, also just give us a parting shot, Dr. Malindi, and anything you'd like to tell the people and also the government out there.
Thank you. So I think, as Dr. has said, this shift is good, yes, but if we still don't manage it well, it will go down to drain. Because at the end of the day, you know, for us who have pay slips, we are saying it's an easy target. They can actually, it will be implemented immediately. Employers and house levy immediately, shift immediately. But now the problem will come with this 80% of Kenyan population, they will have said. So if they don't reduce corruption and manage the money properly, we'll still go back to the same problem. So now, since they have started it, we are expecting as from next year, as from the next financial year.
It starts in July?
Yes.
Yeah. Okay.
So now we expect to see changes in our hospital. We should not come back next year with the same story that I went to hospital and there was no medicine, there was no this, there was no this.
Perhaps this is it for us, guys. We don't know. Let's give them the benefit of the doubt. We see if things will change, but clearly the building blocks of health systems need to be improved. They gave, from a scale of 0 to 10, they gave 3, they gave 4. We're even below average, and there's so much to be worked on. They've mentioned about the healthcare facilities, accessibility, the workforce. Those are the major things that they have mentioned, and also the mental health for the doctors as well. And right now, it's time for us to say goodbye, but thank you so much for tuning in from the start until the end. It has been Health and Wellness. In case you missed this episode, find it on YouTube at KTN Home, and our socials at on Instagram at KTN Home _ and on Facebook at KTN Home. My name is Zaitun Ali. Thank you so much. Until next time, thank you.